So our speakers today. Chelsea Davis graduated with a Bachelor of Science in Nursing with distinction from the University of Alberta in April 2023. Since then, she has worked as a registered nurse in both neonatal and pediatric intensive care units. She began her graduate studies in September 2024 and will soon complete her Master of Nursing in Research. Her work has been driven by a desire to improve family experiences in the PICU, specifically in palliative and end-of-life care. She is joined by Dr. Sadie Deschênes from the Faculty of Nursing at the University of Alberta, who is an assistant professor. Her doctoral research focused on developing, implementing, and evaluating evidence and ethic-informed moral distress interventions for intensive care units. Dr. Deschênes' research interests include ethics, moral distress, intervention development, healthcare professional retention, and improving Indigenous peoples' health in critical care settings. Without further ado, I pass it over to you both. Thank you again for being here.
Thank you, Michael, for that great introduction. So as Michael has mentioned, my name is Chelsea Davis. So I'm a registered nurse and an MN student, almost finished the program. I do work in both neonatal and pediatric ICUs at the Stollery Children's Hospital for about 3 years now. And yeah, I'm doing this study entitled Exploring Families' Experiences with End-of-Life Care and Processing the Death of Their Child in the Pediatric Intensive Care Unit. Joined with me here is Dr. Sadie Deschênes, and so she is my supervisor with the Faculty of Nursing, and a co-investigator of the study as well, Dr. Daniel Garros, a pediatric intensivist in the PICU. So yes, without further ado, I'll just go ahead here. I would like to start off with a land acknowledgement. So I want to respectfully acknowledge that here in Edmonton, we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. All right, so for the contents of this presentation, I will start off with explaining the process of end of life in the PICU, review some key terms, touch on some of the background to this study and literature review, outline what exactly the study objective is, discuss the research design and overview of the methods, and then I'll provide some study updates as well as the preliminary findings and emerging themes so far. That is where we'll focus most of the presentation. Then I'll discuss some of the limitations and challenges. And lastly, I'll highlight some of the potential contributions of this research. And I have created some questions for consideration at the end. So as Michael has mentioned, if you have questions to pop in the chat, I may not be able to see them throughout, but we'll definitely get to them at the end. So with that said, I will formally get started here. So what exactly is end of life in the PICU? Oh, apologies. There we go. So the end-of-life phase is a complex and under-researched phenomenon in ICU settings, particularly with pediatric patients under the age of 18. For prevalence, the mortality rate roughly ranges between 2 to 3% of patients admitted to the PICU, but this is dependent on each site and the timeline or season we are looking at. Due to the severity of illness and patient population, the majority of pediatric deaths in hospitals do occur in the Pediatric Intensive Care Unit, or PICU. Families who have experienced the death of a child in the PICU express intense feelings of depression, anxiety, and regrets about the actions, choices, and decisions made surrounding the time of their child's death. Cultural and spiritual care during end-of-life phase in PICU has often been left as a last priority for a multitude of reasons, some including a lack of awareness or discomfort from PICU staff, prioritization of medical care, or sometimes lack of available resources to support the family's needs. So I want to highlight some key terms here, as the language I'll be using may not be familiar to everyone, and some of these terms can be used synonymously, but may not all mean the same thing. So I'll start off with advanced care planning, is an extension of the treatment plan, encompassing both short-term and long-term goals and treatments. It may be inclusive of a formal advance directive, which specifies what treatments will or will not be provided. Advanced care planning ensures that both curative and palliative goals of care are aligned with the patient's planned course of treatment. Bereavement is defined as the objective reality one faces due to the death of a person important to them. It is characterized by the stages of emotions one goes through when they experience a loss and may include anticipatory grief beginning before the person's death. End-of-life care is provided to individuals near death who have ceased treatment to cure or control their disease. End-of-life care may include physical, emotional, social, and spiritual support for patients and their families. The goal of the end-of-life care is to optimize patient comfort via the control of pain and other symptoms. Palliative care is defined as specialized medical care focused on providing relief from the symptoms and stress of a serious illness. Palliative care is based on the needs of the patient, not the prognosis, aiming to improve quality of life for both the patient and their family. It is appropriate at any age and at any stage in a serious illness, and it can be provided alongside with curative treatment. The Pediatric Intensive Care Unit, or as I'll refer to as PICU, is a specialized unit which provides care to critically ill infants and children. So some of the background and literature review. So end-of-life care, as part of the palliative care strategy in PICU, plays a crucial role in supporting families facing the loss of a child in the PICU. Discussions early on are found to be helpful in identifying what the families need. Additionally, using goals of care planning ensures families are supported throughout the process and that treatment decisions are in line with their desires. This has been shown to have a positive influence on preparing families for the death of their child and supporting the beginning stages of their bereavement process. Studies have shown that losing a child in the PICU is an emotionally and psychologically overwhelming experience. In this time, families desire honest and timely communication with the healthcare team, a natural and private environment to be with their child in their last moments, and better provision of resources to support their child and the entire family during the end-of-life process. However, this has not been well achieved or meaningfully implemented for families, and families have expressed feelings of vulnerability, regrets around the choices made for their child's death, and a lack of control or even hopelessness. PICU staff have also expressed a fear and discomfort regarding end-of-life discussions. Many have identified a lack of competence in participating in the decision-making process during end-of-life. Many nurses have expressed strategies of avoidance and silence due to uncertainty over how to discuss the process of dying and how to best support families with their child's impending death. Evidence suggests not all nurses are adequately prepared or trained to provide compassionate end-of-life support in the PICU, especially for the holistic needs of families beyond the physical medical support. Further research has been suggested to understand how the unique cultural, spiritual, and socioeconomic needs of families are being addressed during these challenging times. Maintaining family traditions and cultural practices during hospitalization is considered highly valuable to families. Nurses tend to approach this care dependent on their personal beliefs and values and the accessibility and familiarity with the resources of our multidisciplinary team, such as spiritual care, child life, Indigenous liaisons, and social work. There remains a gap in our understanding of how meaningfully the current use of resources are implemented and where families would appreciate greater support and resources for their cultural, spiritual, and socioeconomic needs. So what is the study objective? The purpose of this study is to explore how families experience end-of-life care meaningful to their unique cultural and spiritual backgrounds in the PICU surrounding the time of their child's death. So to talk about methods of how this study has taken place, I'll start by describing the research design. So interpretive description was the chosen design for this study for a multitude of reasons. With appreciation for the complexity and intimacy of the research questions to be addressed in the study, a qualitative approach was chosen, particularly interpretive description, with relational ethics as an analytic structure. As Sally Thorne describes, interpretive description takes a more pragmatic instead of theoretical approach. It was created for health-based research and uniquely relevant for the nursing discipline, with a design built for translation of findings into clinical practice. Relational ethics is the analytic lens through which I am viewing the experiences of families in the study and guiding how the findings can dignify, engage with, and provide meaningful insight for families who have lost their child in the PICU and for those who will experience this hardship in the future. So some of the core research questions that have guided the interview guide that I've created is, how do families experience end-of-life care in the PICU surrounding their child's death? Which end-of-life care practices were most valuable to families during their dying period of their child and why? And how meaningfully has the PICU addressed the cultural, spiritual, and/or socioeconomic needs of families during the end-of-life process for their child? So in terms of eligibility, eligible participants included parents or legal guardians above the age of 18 who have a child who died in the PICU during the approximate time period between 2022 to 2024. The participants were recruited by consulting the death registries maintained by Stollery's Aid for Assist and Serious Illness Support Team, or ASSIST, which is our palliative care consulting team at the Stollery. Contact with families was made through a recruitment email, which was sent by a member of our ASSIST team. The selected sample aimed to represent diverse backgrounds, ideally including Indigenous experiences and immigrant families. Although with limited response rate, this has been difficult to obtain so far. After comparing similar research studies and to attain a sufficient sample size, seeing patterns in themes without doing an injustice to the topic, a sample of 8 to 10 participants is the goal. So I have collected the data using semi-structured interviews via Zoom or in person with families by their discretion and/or availability. I have been using an iterative approach with concurrent data collection and analysis, using field notes and reflexive journaling throughout the process. I'm using thematic coding with pattern formation, aiming to draw out meaningfully relevant findings for clinical practice and resource development. So where am I at right now with this and the study updates? So I began interviews this January after many delays with getting ethics approval last year. They are still underway. A total of 59 eligible participants were emailed by ASSIST. Of those, 15% or 9 participants have expressed interest, and 5 have been interviewed so far, including 3 mothers and 2 fathers. Of those taken place so far, their child's death occurred 2 to 4 years prior, between the years of 2022 to 2023. 3 participants chose a Zoom interview and 2 preferred to be in person. Ideally, with the contact so far, we will reach the sample goal after just a few more interviews. So now to the preliminary findings and emerging themes so far. So the first one I wanted to talk about was nursing care. So a quote from a participant here was, "Your experience in the PICU entirely depends on who your nurse is." Now, most comments about nursing care were met with gratitude for the incredible care from our PICU nurses. But some mentioned inconsistencies in feelings that some nurses seemed uncomfortable having those conversations about end of life, and that added negatively to their experience and processing. This highlights a need for standardized training to avoid inconsistencies in care and improve the comfort level surrounding the nurse's role during end of life. The next would be about primary physicians and consistency in opinions. So shared amongst the majority of participants was the desire to have a primary physician. This is commonly offered in PICU to improve the communication with families. By having more consistency and less differing opinions, it helps families feel supported on their informed decisions and less overwhelmed by hypothetical options during end of life. This should always be communicated and offered to families early on in the palliative and end of life care process, as of course possible within the limitations of the child's illness and progression. The next I wanted to talk about was honest and complete information. So this is a theme shared by existing literature and all study participants so far. So parents may express a difficulty hearing and processing the information about their child, but they desire to be told the complete truth. In an attempt to use more sensitive language, staff can sometimes sugarcoat the realities of what is happening, which take away from the ability for the family to make truly informed decisions for their child and to begin processing their child's impending death. It is important to families that they feel respected in these conversations, and that all of the multidisciplinary team, including nurses and doctors and other staff, are consistent in this type of communication. Another comment was about the timing and location in conversations. So a quote here was, "Sometimes the timing of those conversations are off." In terms of timing, a couple participants mentioned that due to the efficiency and flow of the unit, the timing felt that it was better for the healthcare team, but not necessarily in tune with where they were at in the grieving and processing of what was happening. It is a reminder to always check in with families and allow them some leniency in self-directing the timing of these conversations where possible. In terms of location, a quote here is, "A private space is a better spot to have those conversations, one-on-one or with the family, about the care plan, because then there's no distractions around and they can actually hear you." So some varying opinions existed among the participants here. Some preferring to remain in the room with their child, and others wanting a private, natural room to have conversations, especially regarding goals of care and end-of-life discussions. Regardless, they all desired an environment with minimized distractions and to be given the space and supported to make those decisions for themselves as they find is best for their child. It's important to consider that in like the ICU environment with all of the noise and busyness and distraction, that this type of environment can take away from the family's ability to really make decisions without feeling too overwhelmed. The next comment I would like to talk about is weekend availability. So a quote from a participant here was, "Our big struggle was it was Saturday, so it was the weekend. I know there's the family room, but they had it closed. And so I walked out into the hallway, and that was our grieving spot, which seems absurd because babies don't die on a schedule. So there was my whole family out in the hallway in the middle of everyone walking past. And then I'm just a puddle on the floor. It was frustrating that those spaces exist and were unavailable." Having a child pass away on the weekend was the experience of a couple participants, and it was a very important one to consider. The PICU is 24/7 care, yet a lot of our additional interdisciplinary supports and resources are available on an office schedule, Monday to Friday from 8 to 4. And especially for cases of precipitous deaths, this allows some families to not receive the support they need and deserve during their child's death. The comment that children don't die on a schedule is profoundly important to consider with the way we allocate our resources and accessibility even to private spaces such as the family room. The majority of participants interviewed were experiences during COVID. So these experiences were amplified by resource constraints and visitor limitations, exacerbated by this lack of support. Still relevant today, it is difficult for families who have to work during regular office hours and may not be able to take advantage of resources such as the family room or those whose children pass away at night or on the weekend. In terms of sibling support, a quote here that was mentioned is, "There is no place for the kids to go to get a break." So to continue off of the last theme, it is the need for support for siblings and families expressed uncertainty over the appropriateness of having siblings in the room and their developmental ability to understand what was happening to the other child. Many parents felt a difficulty in being a good or adequate parent to their other children while managing their own emotions and grieving process of their dying child. Some expressed feeling like a failure to their other kids and not knowing how to support them prior to and following the death of their child. Some mentioned that there would be certain birthdays or things of their other children which they could not attend to in the way that they felt would be valuable because their mind was focused on the death of their other child, taking away from their experience as a parent. These conversations should be encouraged, and resources would be helpful to support families with their other kids beyond traditional office hours, especially for those with greater socioeconomic concerns and a minimal family support system. Another difficulty was expressed in finding an appropriate child psychologist after the death of their child to support siblings through the grieving process. And there was barriers met with funding, accessibility, and financial needs to receiving these supports. Oh, Sorry, it seems that the slides have decided to reload. I will just try and reopen them. Okay, perfect. So the next one here is on speaking with someone who has gone through this type of loss. So a quote here is, "Unless you have gone through it, you just don't get it." So multiple participants expressed a desire to speak to other parents who went through the same thing. Unfortunately, many well-meaning comments by staff were not met with the empathy they were intended for, and it seems to come from a lack of understanding for what they are going through. Many support groups that parents reached out to for child loss included parents who have lost children, adult children to overdoses or various other cases, but few with the ability to relate to the loss of a child or infant in the ICU. Although many who attended the Stollery memorials felt more support in this way from speaking with those who had actually gone through a similar type of loss and expressed gratitude for those kinds of events and that they made them a priority. Okay. The next one here is on importance of faith and spirituality. So the quote here is, "I do think it needs to be more encouraged. Not even encouraged, not frowned upon. I think it needs to be a point of conversation with them. What do you guys want as a faithful spiritual family? What can we do to better support you with this?" Those types of things would have been helpful for us. Shared amongst a few participants was the desire to practice their religious and spiritual practices without judgment and with encouragement. Many felt a need to self-advocate for themselves in this way, and an uncertainty over the role of spiritual care workers and whether or not they could bring in their own religious leaders. This invites an opportunity for staff to include this care as part of the conversation, advocating for resources we can provide and supporting these needs as a priority and as the family's desire. Another comment here is on follow-up resources. So this quote was from a mother who said, "You're literally walking out of the hospital, carrying an empty car seat. And so now I have this pamphlet. It's just going to sit on my table." So I've mentioned a bit of the discussion around supports in the hospital, but a huge gap for these resources and for these families was follow-up supports and a negative view of the pamphlets we provide. While not disregarding their value in providing resources such as contacts to funeral homes, it seemed to be given to families in passing, without explanation for its contents, and it was overwhelming to read in the midst of that traumatic time. They also expressed a desire for financial supports. Having taken off work for their child's hospitalization, and now they're grieving as well, unable to afford groceries and the ability to prepare meals for themselves and for their other children, especially for those with socioeconomic concerns and a minimal support system. They've also expressed a need for referrals to trained psychologists in child loss and support groups of those who have gone through similar loss. So our ASSIST team does provide some of these services and resource referrals. Although unfortunately, a few of the participants in the study were not connected with ASSIST prior to their child's death and may have been missed from receiving some of the supports that we do have and offer. This highlights a need for consistency, ensuring that no families are missed in this way, and a greater need to collaborate with community social supports and our hospital level resources. The next I would like to talk about is on the language of bereavement and bereavement timelines. So as I mentioned above, there was some well-meaning yet insensitive comments received around the topic of grieving and the expected timelines around this. So one of the quotes that a mom had received was, "You're not over that yet." And many families had a negative view around this concept and the word bereavement, associating it with the 3 days off work they were given for the loss of their child, as though they were expected to get through that loss in such a short time frame. This highlights an importance of our use of language with these families, ensuring it is supportive and not biased based on our personal views of grieving, timelines, and the expected reactions or emotions in that time and during that process. And lastly, another finding I want to mention is just on gratitude. So the quote here is, "The only way that issues are ever fixed or even known about is with conversations like this." So I wanted to mention this quote because I think it has helped remind me of the importance of this research and not making assumptions as healthcare providers about how families perceive the care that we are providing. Research and conversations like these help to improve the standard of end-of-life care we provide for families in the PICU. So next, I'll just mention some of the limitations and challenges here. So limited resources and funding for this study added challenges, including the ability for translation services and providing financial compensation to participants for their time. As I mentioned prior, ethics approval took many months due to the nature of the study and resource limitations, adding more difficulties to the study and to the recruitment. And again, with the challenges faced with recruitment of a diverse representation, as was the goal of the study. But again, we were only able to work with those who had responded to the email. Some other challenges included the distress of the subject matter on families. Resources were provided for families if they needed psychological support during or after the interview, including a 24/7 distress support number and contact to local and online bereavement support groups. They were also given the opportunity to remove their interview data at any point up to 2 weeks following their interview. Participants provided informed consent prior to the start of the interview, as well as the chance to ask any questions throughout the interview process. So now I just want to talk about some potential contributions, and then I have some questions for consideration for all of us. So the findings from this study have the potential to improve end-of-life care in PICUs. They aim to do this through increased awareness that may contribute to improved staff education and resources targeted to deal with end-of-life and the decision-making process. More meaningful implementation of culturally and spiritually sensitive end-of-life care in the PICU through better provision of resources tailored to the individual family. To minimize moral distress and improve staff capacity to deal with difficult conversations by prioritizing education for these nurses. Based on identified opportunities from the findings of this study, it aims to guide further research that informs ongoing improvements in end-of-life care in the PICU and hopefully that of other ICUs as well. Lastly, I wanted to add a personal perspective on why I chose to do this study, other than the results seen in the literature. I can't speak from the perspective of medical education, but I can speak on behalf of my experience as a nurse. I have attended the U of A for both my bachelor's and now my Master of Nursing degree, and only had one lecture in my undergrad regarding palliative care and dying. In both my training in NICU and PICU at the Stollery, I received months of classroom instruction on life-sustaining and critical care. I also receive yearly recertification and training and updates from both units. Yet there was no formal or mandated training on palliation or end-of-life care and conversations other than that of ones that you have to self-seek out, despite its prevalence in both units. In speaking with many of my coworkers and reading the literature, this is not an isolated phenomenon. Understanding that we would never be expected nor legally allowed to do CPR on patients without the yearly recertification, I don't believe it is ethically responsible to expect nurses and healthcare providers to provide meaningful and competent end-of-life care to families in PICU without formalized training. It is not a coincidence that it remains one of the largest causes of moral distress in critical care nursing, threatening the sustainability and longevity of the workforce. Despite the incredible staff who have been there during the most difficult losses in the PICU, nurses remain underprepared to fully support the needs of families going through this unimaginable kind of loss. And those families deserve meaningful, comprehensive, and compassionate support. So even if it just helps to improve the experience of a couple families, my hope is that this research will be a step toward improving these families' experiences. So next, I have created some questions for consideration. And now maybe it would be a good time to stop the recording and allow people to respond via the chat or unmuting. But I will also help allow Michael to help with this.